All right. Thank you, Cameron. Thank you for having me. So I want to talk a bit today about how drug distribution actually unfolds across the villages that we're targeting for treatment. And I'll be focusing on the preventive chemotherapy NTDs, the ones treated with mass treatment. Let's start with something that we're all familiar with. Well, I assume we're all familiar with, the London Declaration. So this was released on January 30th of 2012, and it's arguably one of the most impressive commitments to increasing the access to medicines. It got together NGOs, governments, and pharmaceutical companies that they were either donating drugs or committing money to reach the poorest communities and ensure that they're actually getting the drugs that they need. So this arguably predominantly, again, affects the preventive chemotherapy NTDs. So I was a bit curious, what have we been talking about since the publication of the London Declaration? And being an academic, I decided to mine the literature. I went to PubMed. I looked for all the publications that were released from January 30th, 2012 until practically present day, until Friday. And what this word cloud shows you is, by the size of the word, the most frequently discussed terms in relation to schistosomiasis, lymphatic filariasis, onchocerciasis, soil-transmitted healness, and trachoma, the 5 sets of diseases treated by mass drug administration. And what we see here, out of the 7,193 articles that have been published, we are still talking about morbidity control, infection dynamics. So when we refer to communities, we're still discussing predominantly biological issues. Well, I thought maybe this analysis was a bit unfair. Maybe I should purposely include treatment or the access to medicines when I look through these articles and see what we're talking about. Well, it doesn't change much, and actually the word community becomes used a bit less often. So I'm wondering, where are the articles and research about affordability, about access strategies, drug delivery, patient adherence, and a number of other things I think all the panelists on this Access to Medicines group will discuss today? And going back to mass drug administration, I don't think we can talk about access or communities without referring to mass drug administration. It is our access strategy right now for the most prevalent NTDs. And if we look into mass drug administration, whether we're looking at school teachers giving out drugs or we're training lay health workers in a village to go from door to door, it can give us a window to see how we can actually develop new access strategies, whether those are for programs that won't have purely donated drugs, or if we need to target individuals, we still need to understand the successes and the barriers to mass drug administration to design new programs. So I've been focusing on community-based mass drug administration, predominantly in Uganda. I'm a schistosomiasis person, and we all tend to have a favorite spot, which happens to be around Lake Victoria in Mayugi district, because there's incredibly high prevalence of schistosomiasis. It's also co-endemic with hookworm. In this area, they receive praziquantel in the first week of treatment by door-to-door campaigns, and then the lay drug distributors need to return to all households and give out albendazole and ivermectin for lymphatic filariasis. So we can look at the impact of hookworm because they're treating lymphatic filariasis, but the drugs aren't actually donated to treat hookworm in these villages, even though it predominantly affects adults. It's given out through schools. So to understand how mass drug administration was unfolding across these areas, we started tracking over 20,000 people since 2012. This was a huge study in collaboration with the Ugandan Ministry of Health. We trained over 200 technicians, lay village members, Ugandan master students to use these tablet computers to give us some data in real time. So we developed an app using Open Data Kit, which is released by the World Bank. Anyone can use it to try to understand where the drugs were going, who was taking the drugs, and why weren't they getting them. Well, if we're going to talk about communities and talk about where the drugs are going, I don't think we can limit our discussion to patient adherence. And this is one of the take-home messages that if you get nothing from this talk, I hope you take this today. So if we looked at patient adherence, people that are actually swallowing the drugs that they're offered, this is really highly correlated and determined by our access strategy, so our drug delivery rates, the percentage of people that we end up treating in the first place. And I want to further emphasize that this is an access issue by looking at the profiles of the people that don't get treatment. if we look at developing treatment strategies for NTDs, a lot of the resources that were attracted to start developing new drugs or the mass treatment programs were because we're treating vulnerable populations. But if we look even through our blanket strategies, where by definition it should not be a discriminatory approach, we still find that individuals are marginalized. The people that are the least likely to get treatment are not only the ones that are infected, but they're the ones that have the lowest socioeconomic status, they have poor water, sanitation, and hygiene behaviors, and they belong to minority groups within their village. But we can't just look at the characteristics of an individual. It's really important to understand the community that they're embedded in. So if we take these red dots, each one represents an individual. The simplest example is that they don't exist in isolation. They have relationships, they have friendships, they trust people for health advice. These ties are what determine the behaviors they engage in, the information they receive about the drugs that are available, and their willingness to ingest the drugs ultimately. And these ties are embedded into a larger network structure. This is an example of one of our Ugandan villages, where the structure of these ties determine how information unfolds across the village. If I give you one example about how this is affecting drug distribution, when we went and we looked at everyone's placement in their village network, the individuals that were least likely to receive drugs were on the periphery of the social network. So this was quite interesting because it actually captured that diverse profile of characteristics without us having to go to different villages and have this checklist, because that will certainly vary based on your context and the country that you're working in. But these properties that exist in these social networks don't vary across different areas. All social networks have these properties. You have very few individuals that have most of the connections that are really well embedded. They're this blue node here, central in the network. Yet, in most of the individuals that have very few connections. Now, the reason that these individuals were least likely to be treated, the ones that were on the periphery of the network, is because we're working with volunteer drug distributors. Now, you can't assume because you have a volunteer drug distributor, they're purely altruistic just because they're volunteering. These individuals, by volunteering, and I think this is actually a good thing, you can work on the intrinsic motivations of the lay drug distributors, they're gaining social status in their village. But the way that they're doing that is by treating the high-status people who happen to have many connections in the village, the popular individuals. But because information is not spreading from the treated to the untreated households or individuals, it looks as if they're being fair and benevolent and doing their job to the most important people in the village without necessarily needing to go to the periphery of the social network. So what messages can we take home from these few results I've given you today? Well, one, social factors are profiling who's not getting the drugs on the ground. I think access is ultimately getting the drug to the people that need it. So if we're going to develop a drug distribution program where we have limited drug donations, or we need to start charging for the drugs, then we need a targeted strategy, because blanket treatment's likely not feasible, affordable. But what I worry about is that we already have individuals that are marginalized based on their socioeconomic status and these social factors. So how can you design a targeted treatment program without adding further dimensions of marginalization? I think this is something important to keep in mind. Then if we need to access new populations, like for the pediatric praziquantel, previously untreated populations are ones that we don't access through routine mass drug administration. How do we get the information to these new populations? Well, if information's not spreading from the people we normally treat to the ones that are not treated, we can't just assume that once the information's out there, everyone in the community will have it. So we need to design strategies where we are specifically targeting those individuals for information and choosing the influential people in the social network to spread that information. And then finally, if we're going to have the drugs available in local health systems, which I think should be the long-term vision, ultimately we integrate into local country health systems, then we need to incorporate how community interactions are affecting the access to care. And I want to leave you with two questions that I often ask myself is, when we're working with these programs, what do we owe to the populations that we're trying to treat to benefit? And what should we expect from the local countries and the local communities ensuring that the drugs are delivered?